right, good morning. I'm Jeff Campbell. I'm a urologist from Canada. I specialize in men's health, and I'm here today with two very esteemed colleagues to talk about a new and very exciting topic, male contraception. I'll introduce you to our first guest.
I'm Catherine Nam. I am assistant professor in the Department of Urology at University of Michigan.
Awesome. Thanks for joining us today. So, male contraception, very kind of interesting topic we see all the time in the headlines. Can you tell us what it is and what the hope is for what it will do?
Yeah, so contraception is there are male and female options that are available, and obviously they've been established for a long period of time. For the male side of things, there have really been two options. One is the barrier contraception, such as a condom, and then the other one being vasectomy. And oftentimes for urologists, we talk about vasectomies, and it's been a blessing because it works so well. The failure rate is super low. It's about 1 in 2,000 after we have figured out that the vasectomy works. And so I think it's been a blessing and a curse in terms of making way for other birth control options to enter the conversation for men, because vasectomy has done an incredible job of preventing pregnancy and being super reliable.
So, what is the new innovation then on male contraception?
Yeah, so I think the concepts are not new. So one of the options is male hormonal birth control. And so ST is a hormonal gel that needs to be applied every day. And it is a combination of testosterone and progesterone to be able to decrease the sperm production in a male. And Dr. Honig will talk a little bit more about where we are in terms of the innovation and the phasing of the clinical trials. But this is as close as we've gotten to be able to offer male hormonal birth control, which is incredibly exciting.
So, historically, we don't often put young men who want to be fertile on testosterone for, because of this exact reason. So, is this something that would be reversible? And how would that kind of look?
Yes. So the thought is that it will be reversible, and especially with the combination of progesterone, the dosage of testosterone needs to be much lower. And so I don't actually know the data off the top of my head, Dr. Honig might know, but the idea is for it to decrease sperm production while you're on to birth control, kind of similar to the idea of the combination of estrogen and progesterone pill for female counterparts, and for the sperm production to go back to where it was after stopping the medication.
If men are taking testosterone to try to reduce their sperm quality, do they have other systemic effects, either negatively or positively, because they're taking that testosterone?
So for this one, because the dosage of the testosterone is so much lower than the testosterone that you'd be taking for another clinical purpose, which would be low testosterone with the signs and symptoms of low testosterone, they don't necessarily get the benefits, but it does counteract some of the decreased testosterone that the men might experience with the progesterone in there.
Gotcha. What's taken so long? Do you think we will be moving forward with this in the near future?
I do think we'll be able to move forward in the very near future. And I think some of the reasons why it took so long for us to get here is kind of going back to the vasectomy. It is a method that's been available for a long time. It's done 500,000 times a year in the US, and more than 3/4 of urologists are performing it annually. And so it is a very well-known form of birth control that is very reliable. And so with that gold standard, the bar has been very high for other birth control options to make it through innovation to be offered. So I think that's one thing. I also think there's been a lot of assumptions about whether birth control, is going to be, or men are going to be as receptive to birth control the same way that women have been, because historically it's been seen as a quote unquote female issue when really it is a couple's issue. And so especially when it comes to some of the other methods, such as the NST, which needs to be applied daily, there have been assumptions made about, what is the adherence rate going to be for men? Are they going to be able to tolerate the side effects that are known with hormonal birth control, as well as the dropout rates where they try it for a short period of time, but they're not able to sustain it for X, Y, and Z reasons. And so I think there's been a lot of societal and historical reasons as to why it's taken so long, but we've been able to gain momentum to be able to be as close as we ever have been to be able to offer the hormonal birth control and
the injectable hydrogel, which is also a temporary form of birth control.
So if this is a temporary form, which would essentially replace or mimic barrier options like condoms for like young single men, do you think that will have an effect on STI rates? Because a lot of men also use that for protection from that.
Yeah. And, there might be, it would be interesting to follow up in terms of, how one option of birth control can lead to some other aspects of men's health. That being said, right as of now, the usage and the adherence rates for condoms is not perfect either. And so it's hard for me to be able to predict, whether there will be a new increase in prevalence of STIs among the sexually active young men.
And who do you think should be the prescribers for this when it becomes available? Would this be something that you would need to see a specialist for and a urologist is kind of managing it, or an endocrinologist because of the hormone, or something that primary care physicians should be able to give out relatively freely like they do female contraception?
Yeah, that's an interesting question. I think for wide dissemination and for it to be fully incorporated into the arsenal of male birth control options that we have to offer, I do think for the hormonal option, it would be ideal for it to be disseminated or used by primary care doctors, since a lot of the men are receiving care from their primary care doctors already. That being said, I think if there's any other hormonal disruptions that are concerning or other men's health issues that is under the purview of urologists, what I can foresee is that it will also be part of our practice as urologists and also for endocrinologists. And then for the injectable hydrogel, that one, it will be urologists offering that because the method of instilling the hydrogel is very similar to the vasectomy technique.
Very interesting. I think it's great that we're finally, after so many years, getting to a point where this is an exciting time. And so I'm looking forward to seeing what comes of it.
Yeah, absolutely. I think it's always nice for our patients to have different options. And so the fact that there's enough interest and capital going into this to push this forward is a very exciting aspect of men's health right now.
Awesome. Well, thank you very much for taking the time to be here with us today.
Thanks for having me.
Hi, my name is Stan Honig. I'm professor of urology at Yale School of Medicine and the division chief of reproductive and sexual medicine. I've been on the AUA Vasectomy Guidelines Committee dating back to 2012 and the most recent guidelines as well. And I've been involved with male contraceptive guidelines in my practice and also internationally with the European Association of Andrology and the American Society of Andrology.
Dan, that's quite the background. Thanks for taking the time to come and chat with us today.
My pleasure.
I'd love for you to introduce the concept of male contraception, how it differs from what we've been previously doing, and kind of where we're at now.
So historically, for male contraception, we really had vasectomy and condoms and withdrawal. Okay, that's about it. And there are new exciting concepts that have been kind of muttering along for 20 years, where there's some data here and some data there, but it got kind of dropped out of pharma, or a different type of minimally invasive options that never made it to prime time. Now we have a couple of companies, we have some money behind it, so we're getting into phase 2 and hopefully phase 3 trials on minimally invasive options as well as medical options for male hormonal contraception.
So what are the male hormonal contraception and how does it work physiologically?
So the one that is kind of close to prime time, which is called colloquially NEST, which is progesterone in combination with testosterone. Basically, testosterone will suppress spermatogenesis by suppressing the LH and FSH in the brain, and it takes away the intratesticular testosterone that suppresses sperm production. Progesterone does a similar thing, and the combination allows for the testosterone to be given back so the male feels the same. He has that exogenous he has the testosterone in the bloodstream, but not in the testicle. So it suppresses sperm, but doesn't give the same side effects that you might see with progesterone alone or testosterone alone.
Very interesting. Is that something that then when they stop taking it, it will come back?
Yeah, the data, and there's a lot of long-term data. There are WHO studies dating back to 1990, 1996, looking at testosterone alone or testosterone with progesterone that show really minimal pregnancy rates. Not equal to that of a vasectomy, but probably similar to what we see with female hormonal contraception, with large number of patients across multiple countries that have shown efficacy.
Do we think some of the efficacy or reduced efficacy might be the reliability of men to take their medication properly?
Well, that's been one of the concerns. Are patients who are on male contraception going to take their medication? And I think it's going to be for select populations. So it may be the patient that is not ready to have a vasectomy. He's thinking that he may want to have more kids, may not want to have kids, is in a stable relationship. It may be for a younger male who doesn't want to worry about getting someone pregnant. He still is going to need to use condoms for sexually transmitted disease prevention. But there's going to be different populations that will be looking at this. And, this is 2025. Once this gets approved, it's probably the type of thing where you're probably going to be able to get it online. Okay?
Where you can get everything nowadays.
Right, exactly. And, one of the nice things about other innovations in reproduction and sexual medicine, we have these home kits that can test for sperm. So certain sperm home kits can test for less than 250,000 sperm, which really puts you at a fertility rate that's probably equal to that of female contraception. So if a partner is concerned, she can ask her male partner to test his semen. He could show her the result on this home kit, and you can see that your results are what you would expect, less than 250,000 sperm, which puts you at a very low risk of pregnancy.
Yeah. So it takes almost 3 months to make new sperm in the testicle. So is this something that, if they miss it for a week and then go back on it, is it that the sperm quality will fluctuate, or do they need to go off of it and then that reversibility takes months?
Well, really, reversibility will take 3 to 4 months. And there's good data to show that you'll go down to virtually zero, and then you can bounce back in 3 or 4 months. We know that from patients who are on testosterone in general, and we know it from older studies that show that it bounces back pretty well. Not everyone will bounce back to where they were before, but most people will, and most people will bounce back to what I would consider a fertile level.
Will patients be tested their fertility though before they go on treatment?
Right. So the phase 2 trials included healthy men that had what appeared to be normal sperm production, and then had a run-in phase where they were started on suppressive medicine, and then they were followed for a year where their numbers were less than 1 million. Then the medicine was stopped, and then they looked at the recovery over time. And that data is just being looked at. It'll probably be out in abstract form either by the end of the year or early 2026, and the data will be presented to the FDA to look at moving forward with a phase 3 trial. And the good thing is that there's money behind this now. So historically, there's been money, no money. There've been pharmaceutical companies interested, not interested. So I think this is an exciting time for this because there are trials out there, and there's money to support it as well. And I think there's a major interest in men taking responsibility for their own fertility as well.
So we talked about the hormone modulation. What about the minimally invasive techniques that can also be done?
Right. So there are a couple of minimally invasive options that are new And again, there's money to support this type of thing. And one of the concerns with vasectomy is its reversibility. Okay. The Canadian guidelines say in their guidelines that they consider vasectomy a reversible form of contraception. The AOE guidelines do not bring it to that point, but it says basically after you have the vasectomy, the results are not going to be as good for reversal, and it can be very expensive. So one of the exciting things are some of the what are called hydrogel models that can be injected into the mucosa of the vas. There are two products that are now beginning their phase 2 trials in Canada and Australia, looking at endpoints of safety, looking at efficacy, and starting to look at reversibility. One is from a company called Contraline. Product is called Atom. It's a hydrogel. Basically, it's a water-soluble gel that you inject basically with a 24 angiocat into the lumen of the vas. And it solidifies. And there's good animal data to show that it works. Now we're looking at human data. And there's also the ability to remove this over time. And we'll have to see what the efficacy is, what the reversibility is, what the reliability is, things like that. There's a second product called Vasogel, which has been really out there for 10 or 15 years and kind of struggled going in different directions, didn't have funding. It's now proprietarily called Plan A. And it's similar. It's a hydrogel that's injected similarly into the vas, and it also solidifies. And the reversibility is interesting in that you would inject, it's almost like a bicarbonate solution that would dissolve the hydrogel, and then you'd flush it through. So both of these options are in phase 2 trials in Canada and Australia, looking at efficacy, starting to look at reversibility, things like that. So I think it's a really exciting time for male contraceptive, both in the minimally invasive world as well as the hormone world.
Are the minimally invasive options meant to be reversible? Is that the benefit, or?
Yeah, I think that's the goal. The goal is to offer something that's minimally invasive that is potentially reversible.
And this would be something that is done under local anesthetic, a little freezing, and then just place like
exactly similar to a vasectomy. You have local anesthesia, you pull up the vas, you take a 24 French angiocath, you pass it into the lumen, you pull out the needle, and then the proprietary medication is injected with a gun, and one is theoretically removable, the other one is dissolvable. So again, we'll have to see what the efficacy is, because the bar is so high with vasectomy. The failure rate is 1 in 2,000. So the bar has to be really, really high for this as well in terms of efficacy.
Yes, it's hard to replace something that already works so well.
Exactly.
What do you think the barriers will be, or if there will be barriers with the FDA to get clearance?
Well, the FDA is the FDA. So you can't necessarily predict what's going to be. But, one of the concerns is really side effect profile. And I think we're going to have to look at the results of the phase 2 data to see what the safety barriers are. And that's, I think, where the FDA issues will come up.
Awesome. I think this is it's nice to see that this is finally kind of coming to a point where we might start seeing it clinically in the next, 5 years, hopefully, optimistically. And I think the journey has been quite long, so it's nice to kind of see a bit of a light at the end of the tunnel. I appreciate you taking the time to be here with us today to talk about it. And hopefully we'll see you prescribing this for patients soon.
Well, it's not ready for prime time, but we're excited to see where this is going. We're hoping that the phase 3 trials will be moving forward on medical therapy for an ST in 2026.
Awesome. Thank you very much.
My pleasure.